Thank you, Arthur. I want to thank Arthur and organizers for the invitation. It's actually the third time I come to Krakow. Hope it's not going to be the last one. I always have a great time when I come over, and Arthur is a great host as well. So today I'm going to talk about Waldenstrom's macroglobulinemia. That's my area of expertise. At the Dana-Farber, we have the Bing Center for Waldenstrom's macroglobulinemia. It's a center of about 24 people working on the laboratory, basic, and clinical aspects of the management of Waldenstrom's. I'm the clinical program director, and we probably see about 800 patients with Waldenstrom's every year in our center. We were talking about earlier, I see probably about 6 new patients to my practice, not newly diagnosed, but new patients to my practice on a weekly basis. So there's a lot of those patients that come to see us. It's interesting because in the entire country of the United States, we don't believe there's more than 25 or 30,000 patients, and we have a database that almost approximates 2,000 people with Waldenstrom's that have come to see us throughout the years. So today, when we're talking about Waldenstrom's, we're going to be talking a bit more about who Waldenstrom's is and what the disease is all about, the differential diagnosis, and how do we approach the treatments, the criteria to treat, and then a little bit more about the new treatments and what is coming in clinical trials as well. So something that I always present here is my email address. This is my email address. If you have a question, you have a case that you would like to review, and you would like to have some expertise on that, please feel free to email me. I promise to get back to you, within 24 hours if I'm not flying to Krakow. All right, so these are my disclosures. I'm going to leave them here for a few seconds. And that's about it. Good. So this is the man. This is Dr. Jan Gosta Waldenstrom's. He described the disease that we're going to be talking about. He presented a couple of case reports in patients with severe anemia who presented with hyperviscosity, oronasal bleeds, and with a fatal disease. And he actually saw a lymphoplasmacytic infiltrate in the marrow. He actually called it macroglobulinemia because he saw a large protein in the serum of these patients. He didn't even know it was IgM. IgM was actually described much, much later. Now, Waldenstrom's not only described macroglobulinemia, he also described a number of other conditions and diseases like autoimmune hepatitis, like primary immunodeficiencies. So he was a very prolific clinician. He was not a laboratory doctor, he was a clinician. He was proud of that. He was saying, I'm just a clinician. I just report what I see. And that's what I'm trying to do as well. So people come to my clinic, patients, and they still ask me, so what is Waldenstrom's? Is it a lymphoma? Is it a myeloma? Maybe it's a lymphoma with a side of myeloma. But in this specific situation, the WHO classification states that Waldenstrom's is a lymphoma. It falls into the category of a lymphoplasmacytic lymphoma. And lymphoplasmacytic lymphoma is interesting because it's not a one clone issue. There's actually 3 families of cells that belong to the same malignant clone. So we have the lymphocytic component, the lymphoplasmacytic component, and the plasma cell component. All of them are related, clonally speaking. And we know that because they are restricted for the same light chain, but they also carry the same mutational genetic information. So over 90% of our patients, 95% of our patients with Waldenstrom's will have an involvement of the bone marrow, and that's how we make the diagnosis in the large majority of patients. It's very rare the patient that has extra medullary involvement without medullary involvement, but we have seen it in very few cases. So interestingly, it's a whole body disease. We know this because we have taken sometimes organs from patients, either cholecystectomies, appendectomies, or prostatectomies. And we always see a little bit of Waldenstrom cells pretty much in every surgical piece of tissue that you obtain from these patients. So it's a whole body disease. There's no stage 1 Waldenstrom's for that matter. It's a diffuse process. So here in the marrow, biopsy in the aspirate and the lymph nodes, we see the presentation of the 3 different types of cells present and that's how we suspect about the diagnosis. In addition to the presence of the marrow, we also have the IgM elevation, and more recently, the discovery of the MYD88 mutation, which I want to be talking about a little bit later. So the differential diagnosis is actually really large. I mean, the fact that a patient comes in with a lymphoplasmacytic infiltrate and an IgM elevation doesn't really automatically say that the patient has Waldenstrom's. And this is Something that I see in my clinic, probably about 15%, 15% of the patients that come to see me actually have, either they are told they have Waldenström's, they don't have it, or they are told they don't have Waldenström's, they have something else, and they actually do have Waldenström's. So these are the typical cases that we see that our patients with Waldenström's end up being. One of them is actually IgM myeloma. IgM myeloma is tricky, obviously, because patients can have an IgM secretion, a monoclonal component of IgM. Very high IgMs as well, similar to Waldenström's. The plasma cells can actually have lymphoplasmacytic configuration. So it could be tricky for the pathologist as well. But and sometimes can actually express CD20, and these patients can present with lymphadenopathy. So that's a tricky diagnosis. But these patients tend to have translocation 11-14, which is almost never seen in Waldenström's. They can have cyclin E1 expression, which never seen in Waldenström's as well. And based on the limited data that we have, MYD88 mutations have not been detected on IgM myeloma. Marginal zone lymphoma is also another problem. These patients can have MYD88 mutations in 5 to 8% of the times, but in these cases, these patients tend to have more nodal, extranodal involvement, much more than medullary involvement, even though sometimes we can see that. Some mast cells are more prominent in lymphoplasmacytic lymphoma than in actually marginal zone lymphoma. And depending on how high the IgM is, the higher it is, the more likely it is to be lymphoplasmacytic lymphoma. But we have seen marginal zone lymphomas expressing a lot of IgM too. And very rarely we have these atypical CLLs or follicular lymphomas that also secrete IgM, that can also have MYD88 mutations, but have other markers in clinical and pathological CD5 expression and lymphocytosis that is very rarely seen in Waldenström. So this is a way in which we can actually differentiate between all these are extremely rare conditions. And this is a very important graphic, because in this study we put about 600 patients here, and we plotted the bone marrow involvement in the bone marrow biopsies versus the IgM at presentation. This is at diagnosis. And we here see that really there is not a correlation. This is all independent patients. Each dot is a separate patient. So we have people with almost no disease in the marrow with 10,000 IgMs, and we have people with 100% disease in the marrow with an IgM that is almost within normal limits, even though they have a monoclonal protein. So what I tell my patients is don't go around comparing your IgMs, because it doesn't really mean much. 1,000 can mean nothing to a patient, and 1,000 could make another patient very symptomatic. So we need to have this in mind. Now, when we have the one patient, then we can follow the IgM for progression, for response. But between patients, these comparisons are useless. Good. So this is the clinical manifestations of Waldenström's. About a third of the patients that come to see me in the clinic are essentially asymptomatic, and they do not need to be treated. But the patients who do become symptomatic, or the patients who are symptomatic, can have a multiplicity of symptoms that can make sometimes the diagnosis difficult. The most common implication is anemia. I would say the reason to treat because of anemia is about 2/3 of the patients. Much more rare thrombocytopenia, very rare leukopenia. About 15% of our patients do present with hyperviscosity syndrome, oronasal bleeds, retinal hemorrhages causing blurry vision, recurrent headaches. 20% of our patients do present with neuropathy, typically sensory, demyelinating. Axonal is rare, so motor is rare, and in this type of patients. Very rare, we can have lymphadenopathy or hepatosplenomegaly. We can have cryoglobulinemia and cold agglutinemia, and sometimes amyloidosis and extramedullary disease, which we will see a little bit later. So in talking about anemia, we have identified recently that about 1/3 of the patients who present with anemia actually have iron deficiency anemia. And this is not something that we essentially think too much about these patients, but it's something that I have started to do in my clinic. Somebody comes with anemia, no other implication of the disease, so I check iron levels, iron, TIBC, ferritin, and actually 1/3 of these patients will have iron deficiency. These malignant cells can produce hepcidin that actually will block the absorption of iron in the gastrointestinal tract, and these patients can actively be iron deficient, and then they will need to be scoped. We need to do a colonoscopy, make sure there's no other reason for the anemia. But these patients do respond to intravenous iron, and we do this even before we establish Waldenström's treatment, just to delay the exposure to therapy if it's not necessary. So again, we don't treat everybody because we don't cure everybody, number one. Anybody has been cured with Waldenström's. the survival of these patients is very long. We have patients on the decades, several decades. So we need to treat only when the quality of life of these patients is being affected by the disease. And we use this list, which is a limited list, but sometimes a hemoglobin below 10, platelets below 100, symptomatic hyperviscosity, moderate to severe neuropathy, any type of symptomatic extramedullary disease. It can go from lymphadenopathy to splenomegaly to renal involvements, just 3% of the patients, pleural effusions, 1% of patients, big Neal syndrome, which is leptomeningeal involvement by Waldenstrom's, is about 1% of the patients too. And in some cases, we have to treat because of cryoglobulins, cold agglutinins, amyloidosis associated with Waldenstrom's as well. So again, we need to make sure that the symptom that the patient is complaining of is actually due to Waldenstrom's. So we have many reasons for neuropathy we need to rule out. We have many reasons for anemia that we need to rule out. So, in my practice, I always try to not assume anything. I need to prove that the symptom the patient is having is actually due to the disease. So in that way, I have better chances of serving my patients better. Let's talk about the treatment options. And this is not in a very specific order, but bendamustine and rituximab, for example, is a practice that we use very often in Waldenstrom's. And the reason for that is this randomized study coming from the Germans in which bendamustine and rituximab was compared to R-CHOP, but I want you to look at the sample size. It's a very tiny sample size. It's 20 patients per arm. But in this study, we see that the progression-free survival for bendamustine and rituximab was better than the progression-free survival for R-CHOP. So, and the toxicity is actually better in our experience with bendamustine and rituximab than with R-CHOP. There's no alopecia. There's very little febrile neutropenia. And also the risk of secondary cancers as well. But bendamustine has its own issues too. I mean, it can cause rash, can cause sometimes prolonged cytopenia, secondary infections. So nothing is for free. But based on the toxicity and the efficacy, if we want to use chemotherapy, we tend to use bendamustine and rituximab in our practices. The overall response rate is about 80%, with a very high complete response rate for Waldenstrom's. 20% is a very high complete response rate. And the median progression-free survival is actually about a year, about 5 years. Another regimen that we use very often is this regimen based on cyclophosphamide. There's a number of different phase 2 studies. There's no phase 3 study actually done to prove the benefit of cyclophosphamide therapy, but a number of phase 2 studies from different centers in which the overall response rate is actually about 80% too, with a very good, decent 7% complete response rate. The median PFS is about 3 to 4 years in these patients. The good thing about these patients is this treatment is very well tolerated. The toxicity is very minimal, to be honest with you. Very little stem cell toxicity as well. So, and it's widely available. It basically can be used pretty much anywhere. I'm from Peru. I go to Latin America very often. They use a lot of cyclophosphamide there because obviously bendamustine and bortezomib tend to be more costly. But highly effective therapy that could be used in patients with Waldenstrom's. The other option that we have is bortezomib. This is something that we use often, specifically in younger people, because bendamustine has the 1% risk of causing secondary leukemias, and you don't want to expose somebody who's 50, 55 to a medication that can give a 1% chances of secondary leukemia. So we end up using bortezomib in combination with dexamethasone and rituximab. Look at this response rate, very similar, 80 to 90%, so it's a very powerful treatment. And the complete response rate is about 10 to 20% as well. Very fast time to response. Within 1 to 2 cycles, most patients are actually responding. So we use this very much for patients with hyperviscosity who are young. And since with bortezomib there is no risk of secondary malignancies, in the myeloma data has been extensively studied. There's no really risk of any type of secondary malignancy with bortezomib. So we feel more comfortable treating younger people with these regimens. The problem, obviously, is neuropathy. And, used intravenously, used twice a week, the rate of neuropathy is much higher than when we use weekly or subcutaneously, which we're doing now. Now, using it weekly and subcutaneously, the time to response is actually a little slower, but we have seen that the depth of the response is very similar, and I'm going to be presenting this data shortly as well. So other problems are thrombocytopenia and obviously the need of adding steroids and actually adding shingles prophylaxis as well. A second-generation proteasome inhibitor, carfilzomib, which is given intravenously, was used here twice a week in combination with rituximab and dexamethasone. Similar response rate, 87%. Every regimen we have seen so far has a very similar response rate with a complete response rate of 3%. And really no neuropathy, very, very little incidence of neuropathy, fortunately. But everything has a price. It can increase your glucose, can increase your cholesterol, can cause hypo, gamma globulinemia, and other problems as well, in adjunction with the need of shingles prophylaxis. So it's a great option as well if we don't want to give chemotherapy and we don't want to induce neuropathy on these patients. But truth be told, rituximab as a single agent remains the most common regimen used in Waldenstrom's in the United States. This is data from the national database, and I'm going to make this very simple because it's a little complicated. Everything that is black is rituximab single agent. So every year, starting in the mid-1990s until now, the use of rituximab single agent is at least 50% of all the regimens that patients with Waldenstrom's get. This is in patients who are older than 65. So the issue with this is that the overall response rate is 30 to 40%. It's not really that high. And the median time to response takes about 3 to 4 months, so it's not really that fast, But some people respond fantastically to it. The problem is that we don't know who's going to be the one who will respond very well to rituximab very early on. And in addition to that, we have the infusion reactions that can be a problem in Waldenstrom's. Actually, the rate of reactions in Waldenstrom's is higher than any other lymphomas, and this is data that we published a couple of years ago. There is a concept called rituximab intolerance, in which rituximab cannot be longer be given because of the how high the adverse events associated with infusions are in patients with Waldenstrom's. And this is much higher than in CLL, much higher than in follicular lymphoma. The other problem is the flare. Patients who get rituximab single agent can actually flare. The IgM can go higher. And that is not because of progression of disease. The disease is actually dying. But those cells, before they die, they actually shed the IgM they have in them. And they can have a flare. And some of these flares are 25% increase, which is decent. We have had flares up to 300%. So if you have somebody with an IgM of 5,000 and you cause them a 300% increased flare, we're talking about a potentially problematic patient. So, we need to be careful with those patients as well. So several reasons for why in my practice, I don't use single agent rituximab, but there are a number of patients who will benefit from it. We just need to select them better. Maintenance is debatable. We use maintenance a lot in other lymphomas, and we have retrospective data showing that there is a benefit on progression-free survival with maintenance rituximab compared to no rituximab maintenance. This is a non-adjusted analysis. We are submitting an abstract to ASH in which we actually made an adjusted analysis, adjusting for age, sex, what type of chemotherapy the patients received, and maintenance remains getting benefit from progression-free survival. The overall survival benefit, I'm not too convinced about this, but this part I think is a little more solid. So we tend to use it, not on everybody, but I think patients who didn't get a fantastic response and they need a little bit more response, deeper response, then I like to use that. If patients didn't respond, I don't use it. If patients had a fantastic response, maybe they don't need it, right? So we select our patients in a very personalized way. So, but what's new? All this is something that we have been using and we know about this. So the newer things is this, the discovery of the MYD88 mutation. Dr. Stephen Trion reported this in 2012. It's a point mutation in the MYD88 gene. It's a toll-like receptor, gets activated in a continuous manner in patients with Waldenstrom's macroglobulinemia. And actually, over 90% of patients with Waldenstrom's would carry this mutation. And in this study, IgM MGUS had in about 10%, but we know that that number now is higher. So this finding was actually validated in all these studies, different studies from the United States and other centers in Europe and Asia, shown that over 90% of patients do carry this mutation in the MYD88 gene. But we have seen the patients with MGUS also carry this. So about 50% of patients with MGUS would carry this MYD88 mutation. So the MYD88 mutation alone is not diagnostic of Waldenstrom's. We need to add it to the bone marrow involvement by lymphoplasmacytic lymphoma, plus the paraprotein, plus the mutation. I think that increases the certainty that we are dealing with Waldenstrom's, but the MYD88 mutation alone should not be the sole diagnostic criterion. There's a second mutation that my friend Zach Hunter described in the mutation in the gene called CXCR4. CXCR4 has to do with homing cells into the bone marrow. And this is the tail, the C-terminal tail. And there are actually more than 30 mutations that we have seen in this area. And we're actually learning more and more about these mutations. We have nonsense mutations, we have frame shift mutations, and they can actually behave biologically different one from the other. Approximately 30 to 40% of the patients with Waldenström will carry this mutation, and this is going to have probably some therapeutic implications. So in all, we do have three groups of patients. We have the patients who will have only the mutation for MYD88 without mutation for CXCR4. That's about 60% of our patients. About a third of our patients will have both mutations, will be double mutants, and about 10% of our patients will have no mutations, no MYD88 and no CXCR4 mutation. This group doesn't exist. We haven't not seen much patients who have the CXCR4 without having the MYD88 mutation. And when we look at the overall survival, if you have the MYD88 mutation, regardless if you have the CXCR4 mutation or not, your survival is very similar. But if you have no MYD88 and no CXCR4 mutation, this group actually does worse. So we're actually now understanding a little bit better what these double, wild-type patients are. And actually, I think those patients are going to be either a marginal zone lymphoma or an IgM myeloma. So it might not actually be Waldenström's, but actually we're working on that and trying to genotype these patients appropriately so we can learn and know what to do with those patients with worse outcome. So based on all this, the MYD88 mutation signals through BTK, and ibrutinib is a BTK inhibitor. So it made a lot of sense to actually try ibrutinib in patients with Waldenström's, and this is the paper that was published by Trion in 2015. About 60 patients were included in this study, relapse refractory, more than one line of treatment, up to 9 lines of treatment. And really, we don't have to be a statistician to actually, this is the IgM. Each line is an individual patient, and we can see how the IgM improves rapidly with the initiation of treatment. We have patients who feel better within a week, and the hemoglobin also improves. The hemoglobin improves also within the first few months of therapy. This is an ongoing treatment. I mean, you need to take it every day. Those are pills, 3 pills per day, every day. And the patients respond energetically and improve their hemoglobins, and they do feel better, as well. But not everything is great, It really depends which mutations you have, specifically for ibrutinib. We don't know if these mutations have any effect on other treatments, but on ibrutinib, if you have only the MYD88 mutation, that's when you do best. 100% response rate, 100% response rate, with 92% major responses, meaning at least 50% decrease on your IgM. If you actually carry the 2 mutations, the MYD88 and the CXCR4, the overall response rate is over 80%, which is great, but the major response falls to about 60%. And if you actually have none of these mutations, the overall response rate is 60%, which doesn't look that bad, but none of them is major. All of them are just minor responses. And now we believe that depending on which mutations you have, actually the duration of response is going to be shorter. You want to be presenting this at ASH as well. So there is a difference. If ibrutinib is something that our patients consider, knowing which mutations they have is very important, at least from our perspective. Again, nothing is for free. We have side effects with ibrutinib. I have separated them in 2 groups, the early side effects and the delayed side effects, or the long-standing side effects. The early side effects are a little bit of anemia, neutropenia, thrombocytopenia, rash, and all these things that can happen. Typically within the first 2-3 months, these side effects do disappear. And the more long-acting is a different story. They remain, and they actually get worse sometimes with time. The risk of bleeding remains. Ibrutinib affects platelet aggregation and adhesion. So we need to stop ibrutinib before any type of surgery, for example, to minimize risk of bleeding. But the risk doesn't increase with time. Atrial fibrillation, we have seen in about 10% of our patients. It does get worse with time. We think that patients who have been the longer, they are more likely to develop atrial fibrillation. If you have a heart problem, you're more likely to develop atrial fibrillation as well. And hypertension. Hypertension gets worse with time as well. So these data actually led the FDA to approve ibrutinib. It's the only medication approved by the FDA and the European Medicines Agency to treat patients with Waldenström's. And there was a confirmatory study. This is the Innovate study Dr. Dimopoulos here presented this data, and this is a group of about 30 patients that were all refractory to rituximab. These are rituximab refractory patients, and the data was very, very similar to what we saw in the initial study, about 90% response rate, and even though they didn't present the CXCR4, but they did present a bit of the CXCR4 data, didn't make too much difference, but I think the sample size was smaller, but we did detect some differences between these two groups. So I do believe it's a great medication. The main problem is obviously access to it and the cost, right? We're talking about, at least in the United States, about $100,000 per year. We haven't gotten to the median progression-free survival yet, and we're getting to the 5-year mark, so that means at least $500,000 per patient. So it is a very costly treatment, but highly effective based on what we're seeing. So this is an algorithm that I want to be presented at the ASH educational session this year. I have been kindly invited, and obviously I have accepted. So this is the algorithm that we're following in our research center. Doesn't mean that you should do that. But if the patient is asymptomatic, we just watch them. We don't treat them. If the patient is actually symptomatic, we actually genotype them for MYD88 and CXCR4. And depending which mutation group you fall into, we recommend specific therapies. Not everybody will benefit from ibrutinib. Not everybody will benefit from bendamustine or bortezomib. But this is the beginning, I believe, of what we call personalized medicine in Waldenstrom's macroglobulinemia. So there are obviously resistance mechanisms to ibrutinib. CXCR4 mutations can give us lower responses, more superficial responses, and maybe a shorter duration of response. BTK mutations have been reported in CLL and mantle cell, have also been reported in Waldenstrom's. They are all located in the C481S loci. And more recently, we have detected TP53 mutations in about 5% of our patients. And we don't know exactly what that means, but only the CXCR4 mutated patients actually have the 53 mutation. We have not seen it in patients without the CXCR4 mutation. Interestingly, the BTK mutations only appear in CXCR4 mutated patients. So there's a mechanism of resistance right there. And this is the new network of what the MYD88 means. MYD88, CXCR4, the different interactions between them. And by understanding this biology, which obviously Dr. Trion's laboratory has worked a lot on understanding this network, we have come up with groups of agents that could potentially help on treating Waldenstrom's and are going to be getting into clinical trials. So we tried initially idelalisib. It's a medication, PI3 kinase inhibitor. We did a study that was planned to accrue 30 patients, but we only could accrue 5. Out of the 5 patients, 4 patients developed severe AST and ALT elevation to the point that we could not continue treatment on these patients, and we had to stop therapy. So during the 3 or 4 months that patients were on treatments, no responses were seen, so the responses were not quick and were not fast. So we decided that not to pursue idelalisib at this time. That doesn't mean that PI3K inhibition is not good for Waldenstrom's. It might be. There are a number of dual inhibitors coming up that are less toxic. So we are planning to actually do some more studies with PI3K inhibitors down the road. What we're excited about is ixazomib. We're going to be presenting this data at ASH. This is about 26 patients that we put together, very, very typical patients with, CXCR4 mutations were around 15% of the patients. 60% of the patients. Everybody was MYD88 mutated. This is the IgM response. You are the first group of seeing this data, so you cannot disseminate this data. This is secret. This is not to share. So the IgM, the median goes from 5,000. And during the initial induction is 6 cycles. We have a median response by 6 cycles. And then during the maintenance, which is obviously every 2 months instead of every 4 weeks, we see a deepening on the response. So the longer you are on treatment, this is 1.5 years of treatment, we get to almost 75% decrease on almost 80% decrease on the IgM levels. And we see also an improvement on the hemoglobin that follows the response on the IgM. So this is very good. The overall response rate in our group is 96%. It's probably the highest we have seen so far, with a major response rate of about 77%. So we're very excited about this. We're excited because ixazomib is just once a week, 3 out of 4 weeks. And I think the toxicity has been very, very, very manageable. We have not had any major neuropathy. We have not had any major hyperglycemia or hypogammaglobulinemia as well. So you will see hopefully a peer-reviewed article. It's actually in the process of being written. But CXCR4 mutations might actually play a role in how quickly a patient gets a response. These are the MYD88, the CXCR4 wild-type patients, and these are the CXCR4 mutated patients. So the people with CXCR4 mutations respond slower to ixazomib as well. So CXCR4 mutations might not only be important for ibrutinib, but may be important also for proteasome inhibitors. But we have not really formally evaluated this besides the context of being used with ixazomib. And this is the data that keeps me very excited too. We're completing the venetoclax study. This is a BCL2 inhibitor, as we heard before. And we started with 200, then 400, and 800 milligrams, so that's 8 pills per day. But the treatment is only lasts for 2 years. I'm going to present data here on the first 8 patients who have completed 6 months of treatment. We can see the IgMs dropping pretty much on everybody. We have a 100% response rate. We have a 25% very good partial response within the first 6 months. And look at this graphic here. This is the bone marrow involvement of disease. Pretty much all the patients that we have marrowed at 6 months have less than 10% involvement within 6 months of treatment. These are patients who were presented 60, 70, 80, 90% disease involvement before initiation of treatment. So very exciting, specifically thinking about combinations of therapy with using venetoclax, with ibrutinib, with rituximab, with proteasome inhibitors, like it has been done in myeloma as well. So highly exciting. We want to be obviously analyzing this data as time goes by. The ongoing trials, we have completed the frontline ibrutinib study. 30 patients out of 30 will be presented this data at ASH. What I can tell you is as good as we have been seeing, so highly effective treatment. No other safety issues that we have detected so far. But we're doing whole genome sequencing on every patient every year. So we'll see if there's any type of clonal evolution that we will learn from this. And these are the planned clinical trials, just to finalize. We have a randomized study between BGB311 and ibrutinib. BGB3111 is a new BTK inhibitor. It's coming from China. They are claiming that it's more powerful. They are claiming that it has no risk of bleeding and claiming there's no risk of atrial fibrillation. We don't know that. That's why the study is being done. They already said that if they are as good as ibrutinib, they will sell it for half the price. So maybe they will win anyway. It's going to be a multinational study, about 160 patients. We are about to begin daratumumab in patients with Waldenstrom's. It's a year and a half. It's a protracted. It's different than myeloma. Just a year and a half of treatment and see what can we learn from that. And this is also exciting. If you have CXCR4 mutations, this is the study for you. We're going to be giving ibrutinib in combination with this antibody called ulocuplumab that is going to be specifically for CXCR4 patients. So we are moving really forward with what we call personalized therapies based on the mutations that the patients do carry. So at the end of the day, we have learned that Waldenstrom's patients carry the MYD88 mutation in over 90% of the times. We now know that CXCR4 mutations occur in about a third of our patients and maybe confer some resistance to ibrutinib and maybe proteasome inhibitors. Ibrutinib is the only medication approved by the FDA and the EMA for Waldenstrom's, but there's a slew of different agents coming down the road that I think will change how we treat our patients with Waldenstrom's. And with that, I would like to thank you for your attention.
Thank you very much for your excellent presentation. I have 2 questions. Do you have any tool how to predict smoldering Waldenstrom to Waldenstrom?
Becoming symptomatic?
And it's symptomatic. And another question is about composite lymphoma. Sometimes I have a case now, patient with Waldenstrom and with CLL. How you treat such patients?
Yes, so the transformation from smoldering Waldenstrom's to symptomatic Waldenstrom's, there's very little out there on it, to be honest with you. We are actually doing a study right now with Dr. Gabriel, in which we're actually gathering data on those patients. We're seeing them every 6 months. We're gathering blood work on those patients, and whenever we're doing a bone marrow biopsy, we're actually gathering those data as well. So what we're trying to learn is specifically who progresses and who does not progress and why that happens. I think the data on smoldering myeloma transforming into active myeloma is more clean, but in Waldenstrom's is very, very difficult. So really there's no tool right now that exists that we can use to actually say, oh, your risk of transforming or progressing into active Waldenstrom's is this or that. I think, the reason for that is because We have other problems besides the IgM, so the IgM will not be the most reliable. We have patients who become anemic even before they mount any IgM. We have people who need treatment for neuropathy before they have anemia or they have any IgM problems. So it's going to be very difficult to develop a tool. Free light chains has not been so reliable in Waldenstrom's as it is in amyloidosis or in myeloma. So I don't think we can use that in a reliable manner for Waldenstrom's either. So it's a very difficult point. But the research that we're doing is specifically that. We're following smoldering people along. Some of them will progress, some of them will not, and then we might actually come up with more of a molecular signature or maybe a clinical signature that we can come up with, but there's no answer to that question as of now. The second one is the composite. So I would say, we were reviewing this in our data very recently, and I would say probably around 2% of our patients will have a second malignancy in their marrows, and actually the large majority have CLL, but we have a lot of people who have T-cell LGL. We have people who have folliculars, and we have patients who actually have myeloma. I don't think they're actually clonally related. We have not done formal studies on that sense, but I don't think there's a clonal relation. I think it's more two events happening independently. But now with the advent of single cell evaluations, we will be able probably to answer those questions moving forward. The way I manage those patients is basically you have two guys trying to beat you up, right? So whenever one of them acts up, make sure that you treat that one. And if you don't know which one is the one acting up, then you give a treatment that basically will be effective for both agents. Fortunately, ibrutinib, for example, is approved for CLL as well as for Waldenstrom's, so it could be used in this scenario. Venetoclax, if it gets approved for Waldenstrom's, can be also used in CLL, specifically with P53 mutations, that you can use that. Bendamustine is effective as well. So there's a number of options that we could use to actually treat both clones at the same time.
Thank you. Anybody has a question? Last question. Do you have any data about autologous transplantation in Waldenström?
Yeah, so that data, I mean, we're actually trying to put together a consensus paper on what the role of transplant is on Waldenstrom's. And, there are two teams, right? You have the transplanters who said transplant is the best thing ever happened to Waldenstrom's, and you have the clinicians who said, well, if the patients are doing well on single-agent rituximab, why do I have to transplant those patients? So, and really, since there's no comparative data, it's very difficult to say. So most of the data that we have available in transplant in Waldenstrom's is actually registry data. And obviously, registry data has its own problems because there's no comparator. And you don't know what the selection process was. It's retrospective. Some of the data depends on the quality of the registration of the data that you put in there. So there's a lot of bias on that. The data that we have available is the earlier you use it, the better. But that is true for pretty much every disease. The earlier you use it, the better. That's true for myeloma, that's true for lymphoma, that's true for pretty much everything. So I don't know exactly if because of that we need to use it very early on. In my practice, and it's a biased practice, and I understand that, actually I try to use it as much down the road as possible, because I don't think it really provides patients with a great benefit due to the toxicity that it provides as well. So, taking 3 pills of ibrutinib every day, or getting a, beam, or melphalan 200 followed by an autologous transplant. Allogeneic transplant, I think, is pretty clear that people feel that it should not be used in patients with Waldenstrom's, unless it's in the context of a clinical trial. Now, having said all that, I have recommended transplant, autologous transplant, in a couple of patients in the last 4 years that I've been doing this. And I think those patients were basically very aggressive disease, very resistant to pretty much everything we had. So I think there is a role for transplant. I'm not saying there is not. It's just that we need to take it as it is, another option for treatment, and we need to balance the pros and the cons. Since there's no comparative studies, it's very difficult.
You show also very nice data regarding ixazomib plus rituximab. And the comparison between, it's the same. It's, of course, very convenient for patients regarding its appeal, but Velcade is similar. Do you think Ixa is much more efficacy?
I think bortezomib, the data on bortezomib looks better in terms of how fast you can get a response, and I think it's because of the administration of twice weekly intravenous data. And I think that's what basically makes the patients respond faster. I'm not completely convinced that the fact that they respond faster will get them into deeper responses. I don't think that there's data to support that. Very few, I mean, in Waldenstrom's, in some cases, you need to have fast responses, right? If somebody has hyperviscosity, and then you need to have a fast response. That in those scenarios, yeah, I will favor to use some of the agents that have shown to induce fast responses, like ibrutinib, like bortezomib, dexamethasone, or rituximab. But if you are not looking precisely for a fast response, then I think, steady runs, wins the race at the end. And ixazomib could be a very good option. The toxicity has been extremely well manageable from my perspective compared to bortezomib and carfilzomib, for example. And the efficacy is there. You just take a little longer to get there, but you get there.
Thank you. Anybody?
Thank you.
So, thank you very much.